Hi, my name is Natalie Hernandez. I'm an associate professor in the Department of Obstetrics and Gynecology at Morehouse School of Medicine, and also the founding executive director of the Center for Maternal Health Equity. And today I'll be talking about how we do our work at Morehouse School of Medicine in engaging the community to advance maternal health equity. But before I get started, it's always good to center ourselves and tell you a little bit about who I am, my positionality, and how it has really informed the work that we do at Morehouse School of Medicine within our center. I identify as a cisgender Afro-Latina woman. I'm a mother of two beautiful, wonderful kids who, just really push me towards this passion. I have experienced postpartum depression and perinatal anxiety, and so that really roots the work that I do. I grew up in the South Bronx, where we experienced a lot of these structural and social determinants of health that people talk about, which is really where you work, live, pray, and play, how that affects your health. Prior to that, I worked for a civil rights and advocacy organization, overseeing all their maternal and child health programming and working a lot with community health workers. And so again, I center all of this so you can see when I talk about the work that we do, how a lot of that is centered in this. Through these experiences and working in different organizations, I became really frustrated with what I perceived to be inadequate approaches to really reduce the inequities that we're seeing in maternal health and in particular women's health. And I've taken to founding the Center for Maternal Health Equity at Morehouse School of Medicine. My insider positionality with community organizing, research, valuing people's lived experiences is how we do our work and design interventions. So as some of you may or may not know, Georgia is considered one of the most dangerous states for pregnant women and people. We have really high maternal mortality rates. Georgia usually ranks between last or second to last. And the maternal mortality rate is higher for African-American Black mothers. We see rates that range from 2 to 3 times as high. And over the years, it's actually gotten worse instead of better. And a lot of this is due to the rise in COVID-19, which has compounded, but a lot of mental health and behavioral health issues that we're seeing. Additionally, we've continued to see more hospital closures happening within the state. And we have still a lot of counties within the state of Georgia that don't have any type of obstetrician or maternity care provider. And so all of this together has created a really dangerous scenario for women and pregnant people within the state of Georgia. And so because of that, in 2019, our state legislator allocated or appropriated funding to establish a center of excellence. And we just renamed that to be a Center for Maternal Health Equity. We believe our mission is to pursue equity in maternal health by reducing these maternal morbidity and mortality rates, and not just here locally, but nationally and globally, because a lot of our approaches can be applied in other places. But we really see ourselves just focused on women's health and thinking about women's health across the lifespan. Because if it were intervening at pregnancy, it's already too late. And so how do we think about this problem holistically? And so our vision is to end health inequities in women's health across the lifespan. We do our work in 3 different ways. First is research. I mean, that's one of our biggest pillars, where we do translational research, where we work on research that's focused on basic science, which is, one of our investigators is looking at placentas and maternal stress and how that can be passed on and how that affects maternal mortality rates, all the way to population health. I myself am a social behavioral scientist, and so I'm really interested in these root causes and then developing solutions to address those root causes that contribute to inequities. We also have, as a medical school, developed really great interventions. And so how do we test them? How do we look at clinical effectiveness of those outcomes? Or how do we take things that have been done traditionally in medical settings and start implementing them into community settings? And so we have been doing a lot of implementation science. Secondly, we know that the community is at the center of all we do. And so we see ourselves as an information resource hub where we take really complicated information and put it in ways that are meaningful and understandable to the communities that we serve. We also do a lot of capacity building and technical assistance to organizations that are focused on maternal health or women's health and have been doing amazing work, but want to build their evidence base. And so that's, resource allocation, that's being able to evaluate some of the programming that exists. And again, we do this a lot. We do this in partnership with communities. And advocacy. And so we hope that our research can inform policy and advocacy efforts. We know that we can create the best interventions, but if we don't change the structures or if we don't advocate for particular things, then our interventions will only be band-aids to a wide and complicated and multifactorial problem. And so we ensure that our research can really inform advocacy efforts. And then we do a lot of training. We are a medical school, but we just don't train medical students. We train all different types of learners. And so we have our physician's assistant program, which we've been engaged in, our medical learners, our masters in public health, and even our biomedical students. We do this through interprofessional training. And so ensuring that everyone understands their role and they're working together to achieve equity in maternal health. We have a lot of train-the-trainers. And then that team-based training. And again, when I go further in the presentation, I'll talk about some examples of those programs. So how do we do this work? What differentiates Morehouse School of Medicine from other institutions? And we really believe in person-centered research. And a lot of this is through amplifying mothers' or women's voices. We do that by centering the joy and the pain that our communities experience and centering the voices of the communities most affected by the issue. Centering the experiences of Black women in particular is an opportunity to rethink conventional research practices, thereby identifying pathways that can create knowledge associated with maternal health. In particular, the findings of our research studies underscore the value of grassroots empowerment opportunities for our communities and for women so that they understand their human rights as it relates to systemic inequities, power dynamics, and these social structural contexts. We, acknowledge and recognize and continue to yell out loud that women's lived experiences are legitimate sources of data and knowledge, and that requires this eliminating, these boundaries of division that privilege who can be a knower and what can be known. And it ensures that the strategies that we work on are culturally responsive, that they're really centered on people's experiences, so that when we create interventions and when we do research, it's meaningful and can make real lasting impact. The other thing we do when we talk about person-centered research is that we center BIPOC researchers, Black, Latina, communities of color. These researchers, although they have the knowledge and expertise, they are often left out of the table or brought in some type of advisory capacity, knowing full well that they can lead the research. Their lives and experiences haven't been centered in the development and execution of solutions as indicated with funding and other initiatives that are not led by BIPOC women, but often about them. And Black women in this country and in this wonderful state of Georgia have been doing critical work to address the multitude of inequities, often with limited support and resources. And concurrently, we deal with multiple levels and multiple systems of oppression designed to devalue and derail our work. And so without Black women and women of color, the picture is incomplete and the solutions are inadequate. As I mentioned before, a big pillar and how we, engage in our work is always with community, and not just, these helicopter approaches of coming into a community, getting what we need and coming out, but really meaningful engagement with communities. Working with communities in meaningful ways allows us to move away from a rescue narrative. This is where a lot of the scholarship is aimed at, particularly with marginalized women, by intending to rectify the injustice experienced by women who are presumably unable to confront without outside help. And that's not how we want to come in, right? We understand and value our women and our communities. We decenter the individual and center the community in research. We move beyond analyses that that are looking at and demonstrating group differences that reflect inequity, and shift that focus to processes that disrupt that continuation. Our research needs and what we do is to really understand and address the broader cultural understanding of reproductive rights, and look at things like race, class, gender, and immigration experiences. And then rather than looking at risk frameworks, we really look at the assets that already exist in our communities. We know our communities are doing amazing work. And so how do we uplift that? How do we center that in our research approaches? And how do we create different research approaches? And so we use frameworks that center Black and Latina identities and that challenge stereotypes, and employing frameworks like intersectionality, reproductive justice, social justice, research justice, the Sojourner Syndrome. These frameworks give power to the women rather than give attention to those whose voices are privileged in the production of scholarship. And when working with communities, we must value them and make sure that we're building trust and rapport. And that's what we do, and that's what we have been establishing within our communities. The other thing we ensure, and I mentioned as one of our pillars, is that, when you're working on person-centered research, that can help really inform policy. Person-centered research strengthens Black maternal health legislation. And we think about policy recommendations that advance maternal health equity. A lot of them that we have been successful with have been grounded by interviews, not just with the women, but even the providers and Black providers in particular, and Black-led organizations. Because again, we're focused on inequities, and we know the highest rates of maternal mortality are with Black women. And we address, the role of structural racism in creating and perpetuating the Black maternal health crisis. And that's essential, right? For legislation to truly be comprehensive, it must incorporate a racial equity lens. And again, that's how we want to pursue our work. And this means that, in working with policymakers, we ensure that they understand the historical and social context of previous policies, and that they make tangible commitments to addressing these injustices. And this could include, increasing funding to support research that explores the social and structural determinants of health that perpetuate the maternal health crisis. And that's exactly how the center was established, right? We were able to not just focus on clinical, but really thinking broadly and in a multifactorial way about what's contributing to maternal health inequities. So one way, again, in which we center our communities is what we call the PORCH model. And this stands for Positive Outcomes, Research Recommendations, Community Collaborations, and Honorable Delivery of Healthcare model. And in addressing the Black maternal health crisis, we aim to undertake an approach that centered aspects of community and Black culture. And historically, the PORCH of a home has held significant meanings within Black communities across the African diaspora. It has been viewed by persons as a structure that represents community, safety, and intimacy, and where many had sought refuge. I know during the COVID-19 shutdown, the porch was my refuge, and that was a way where I actually started communicating more with my neighbors during that time. And in addition to this, coming together, it's also an opportunity and a structure that has been a place for celebrating positive events. Again, we don't want to always focus on deficits. We know that there are so many assets that exist in our communities. So now I'll go into some highlights of the community enhanced research projects that we've been conducting here at Morehouse School of Medicine within the Center for Maternal Health Equity. And the first one is our Prevent Maternal Morbidity and Mortality Through Mobile Technology app. This app was created in partnership with Georgia Tech and Emory University School of Nursing, as well as Georgia State University, because we saw that there were points where women weren't getting the care that they need, and particularly within that discharge period. Additionally, the most maternal deaths are happening in the postpartum period. And at the time when this was conceived, there wasn't a lot of information out there or interventions or technologies that were really addressing the postpartum period. And so the PM3 app, what we're currently doing right now is to test the effectiveness of it, to see if it does promote better health outcomes in rural Black mothers. And so we are focused with rural Black women. Our primary endpoint is really completing a postpartum visit. Again, we know that 40% of mothers within our state do not complete a postpartum visit. And so we wanted to ensure that this can be a catalyst and some type of, care provider, but in a mobile way to help get women to their appointments. And then we were thinking about things like self-care agency, being able to establish an appointment, really looking at health-related quality of life and patient-centered outcomes, their satisfaction with the resources that they're utilizing, and then their assessment of patient satisfaction with the mobile app. Our primary goals with PM3 is to increase postpartum comorbidity management, to encourage tracking of risk factors, and so that women who get access to the PM3 app also get access to a Fitbit device, a scale, and a blood pressure cuff. And so we encourage and do different things to encourage being able to access those things, providing access to social support and community resources. Again, we did a lot of formative work with women in rural communities, as well as with providers and then people that support women to see what is it that they needed and what they would want to see in a mobile app. And so a lot of these components within our primary goals was informed by this formative research. And lastly, one thing that we wanted to do was really celebrate Black women and Black motherhood. A lot of mobile apps or things that exist weren't really centered on Black women, didn't have the imagery, again, only focus on clinical information. And before we can get there, we need to just acknowledge that you are it, that you can be celebrated, that you can relish in this moment. And we wanted to celebrate women. And so these are the primary goals of PM3. The study that we've been engaged in is our maternal near miss study. There was, a lot of things related to maternal deaths, but nothing was really focused on or getting information from women who almost died. And in the literature, it says, you can learn more about a healthcare system or an issue through maternal near miss than exploring the maternal deaths. And so we developed this study to really explore women's near misses. So these are women who almost died as a result of a birth in the postpartum period and 42 days after postpartum. Our aim was to really think about these experiences and communicate them as data points that can influence maternal health legislation, clinical practice, and healthcare strategies. And we used stories because we know stories are our life's blood. We like to listen to stories, and through stories, we make sense of the world. We also knew that storytelling, particularly in BIPOC communities, are our roots and our wings and offers a space to reflect upon and move through past traumas. And a lot of our women through these maternal near misses have experienced trauma. And so how do we get past that? How do we share our stories, help it to inform, different strategies, and then make it meaningful to the communities that we work with? The frameworks that we use were the 3 delays model, which is a global framework to understanding 3 delays that contribute to maternal mortality and morbidity. And then again, thinking about BIPOC women, not as a monolithic group, but that have various identities, and really exploring those identities and how that affects their experiences. One of our major community partners was Reaching Our Sisters Everywhere, which is a organization, Black-led, that's based in the state of Georgia, but also does national work. And really excited about what we've been able to accomplish. We've conducted 87 interviews, and we're actually moving into a phase 2 of our project, where we'll be exploring not just stories from women, but now stories from their partners and fathers and aunties and grannies, as well as healthcare providers, so that we have a complete understanding of these maternal near misses. One thing that I did want to share with all of you is we did do a video on, what you would like healthcare professionals to know. I don't want the slides to move back and forth, and so what I'll do is I'll play it at the end. And you'll get a chance to be able to hear it. And if it doesn't work, what I'll also do is to the conference planners to send a link so that you're actually engaged with it. One thing that we thought about within our research is thinking about, sometimes when we're talking about maternal mortality or morbidity, working at pregnancy is already too late. And so how do we intervene prior to the pregnancy to ensure that people are living healthier lives? And so, again, I mentioned the life course approach. And so what we sought out to do with funding through NIH, the National Heart, Lung, Blood Institute, was around preconception counseling. And this particular announcement was, how do you take clinical interventions and implement them in community-based setting? And so we sought to test preconception counseling among couples in community-based settings to improve cardiovascular health outcomes before and during pregnancy in Georgia and South Carolina. We did a needs and assets assessment. And so really thinking about, what's currently being done right in community-based settings. Because we were exploring couples and the inclusion of fathers, we wanted to see, well, are community-based practices friendly to fathers? Are they doing things in ways that are meaningful and engaging fathers? We wanted to know what they're currently doing on preconception care, and what resources they would need to actually implement something like this. And then we held focus groups with men and women to see what they prioritize, or what they wanted to prioritize as topics that they wanted to address in a preconception counseling intervention. Our phase 2 was to actually do the preconception counseling intervention that we adapted in community-based settings. I'm happy to report that we got phase 2 funding that will be expanding this work, not just within the state of Georgia and South Carolina, but within the state of North Carolina and Tennessee. And so we're really excited to take this and make it on a larger scale so that, interventions that are invested in can be sustained, and that the community-based organizations that are implementing it gets the resources that they need. The other study that we've been working on is really looking at fertility. And the purpose of this was to understand, again, as I mentioned, these structural determinants or these different factors that contribute to fertility inequity among Black women. We heard from Black women across the country that they felt that their needs weren't being heard, or that they weren't being treated, or that they weren't being listened to. And again, we know that fertility is correlated with maternal health outcomes. And if people are not receiving the care they need when they want to, when they want to have a child or decide that that's something that they want to do, then it has implications later in the future. And so we utilize the same methods we did with the maternal near miss for this one, where we're collecting interviews. We conducted surveys and worked with patient advisory groups like Broken Brown Egg and Fertility for Colored Girls. We did an intensive literature review, and now are creating workshops and modules to educate fertility clinics based off of our research on how to provide culturally responsive fertility care to Black women. Some of the outcomes is we are creating a digital platform, people like me, where we'll have accurate information, trusted professionals, and a social support community for women who are seeking to have a family. And as I mentioned, again, we're creating a curriculum for fertility clinics on providing culturally responsive fertility care for Black women. Another study and things that we've been doing is really thinking about how do we democratize maternal health equity work in Georgia. And these are some of the things that we do through advocacy, patient education, community engagement. We have developed a perinatal care research and intervention network for Georgia which is modeled after Morehouse School of Medicine's Community Physicians Network, where we have shared agreements and have been working with community providers, women, community-based organizations, so that when we have interventions or we have resources, that they're deployed in meaningful ways and everyone's ready to go on day one to really think about research and the information that they need, particularly these evidence-based interventions. So that we can improve maternal health outcomes, specifically within health disparate populations in Georgia. And this first initiative was funded by NIH. And then we, and as I mentioned, we created this multi-stakeholder network, and then did pilot test some projects across this network to see how quickly these interventions were deployed. Then we received additional funding. We knew during the COVID-19, we were thinking about these dual pandemics of structural racism and dealing with COVID-19. And you never forget the time when you heard the calls of George Floyd crying for his mother. And that was a tumultuous time. And we saw this racial reckoning happening. And we didn't know what implications a lot of that had on maternal health outcomes. And so we wanted to explore that. And so we received additional funds through the National Institutes of Health, through the Office of the Director and the National Center for Advancing Translational and Clinical Sciences, to think about this project in 4 different ways. Conducting a formative multi-sectorial needs and assets assessment around these 2 issues. And so doing focus groups and interviews and surveys with the community, first responders, those that people don't typically think about when we're thinking about maternal health research. Then we saw that a lot of people were expressing their concerns or their stressors on social media, and so we wanted to analyze that. And so we did an infovalence study component to look at that, and then see the biological indices of chronic stress from those dual pandemics. And so doing skin conductance and taking hair samples to look at levels of stress that Black mothers had. We also did a pilot feasibility study to monitor COVID-19 and associations with blood pressure and other physiological data. And then lastly, looking at using a method called legal epidemiology. And so creating a county level structural racism indicator and associating that and linking that with public health data sets to see how structural racism is related to maternal health outcomes. And lastly, I mentioned the training, something that's a priority for the state of Georgia and nationally through the White House Maternal Health Blueprint report is diversifying the maternal health workforce. We've known from other disease and disaster that when a provider looks like the patient, there are better outcomes. And this was actually shown in a recent study with preterm birth. And, we also know that research indicates that 22% of Black women perceive their care to be of lower quality. And your socioeconomic status, that doesn't matter. And so how do we create a workforce that's respectful of the communities that we engage in? And we at the center are charged to ensure that the workforce is diversified by not only training more culturally centered healthcare leaders, but also thinking about other types of providers that can be integrated into these models of care. And so one of the first projects that we had related to that, we received funding by HRSA to train our primary care physicians in maternal population health. This was a way to increase the number of primary care physicians, not only trained in preventive medicine, but with a real focus on maternal health. We work with our preventive medicine residency program. Our residents are engaged within the Georgia Department of Public Health. So they have those experiences. They can do their own studies to really address maternal health inequities. We also developed a community-based perinatal patient navigation program. We saw in the cancer space that lay navigators were doing amazing work. And we were like, well, why can't we just replicate this in maternal health? And Morehouse School of Medicine has been leading the way in lay workers and community health workers and patient navigators in that space for over 30 years. And so we adapted our community health worker curriculum to be more focused on maternal health. And our navigators are people from the community who have these lived experiences, who are trained as doulas, trained as community health workers, and trained as lactation peer supports. We graduated our first cohort of 30 and now got an NIH grant to test the clinical effectiveness of this model within a safety net setting. Right now, we're doing this in Atlanta. Our next cohort will be focused on rural communities and also with an emphasis on males and helping them be trained. And so these are just some pictures of some of our navigators during our graduation, and then a community health worker advocacy day that we participated in with the governor in the state of Georgia. We also knew that there were gaps, right? That half of Georgia's counties have no, maternity care provider, and fewer than half of women in rural areas live within a 30-minute drive. Like more than 10% have to drive, hundreds of miles away to receive the care. And so we wanted to fill that void. And so we received funding to be able to establish a residency program in obstetrics and gynecology in rural communities. Morehouse School of Medicine will have the third in the country and the only one at a historically Black medical school. Our clinical training sites will be in rural communities that have and serve significant Black populations. We've signed contracts and already doing pilot projects to start this process and hoping to actually recruit our first resident, not this year, I need to update that, but within the next year, hopefully July of 2024. And then again, I talked about being able to provide respectful care. There's no way that we're going to catch up with training, all of these BIPOC physicians. And so how do we train others who serve our community to do respectful care and to listen and have our patients feel that they're the center of the world, or that they can have a negotiation and how they receive their care. And so we developed a respectful maternity care simulator model for healthcare providers. This was funded by the center as well as the Association of Professors of Gynecology and Obstetrics. And we, decided to do a SIMS curriculum focused on teaching respectful care as a part of the professional development training in our graduate learners, but also our undergraduate medical learners. And graduate learners are residency, and undergraduate graduate are med students, but also nursing programs and our PA program. And then we're looking and evaluating the impact on that patient-provider interaction. We're using validated scales to ensure that people are receiving the care and that they're satisfied with the care that they're receiving from that provider, but most importantly, that they're feeling respected when they're receiving that care. And we're hoping that, we can then test the outcomes that come out of this in different clinical settings. So I want to leave you lastly, Morehouse School of Medicine, we don't do this work in silos. We work in partnership with payers and community-based organizations and other academic institutions and our communities. Because if you want to go quickly, you go alone. But if you want to go far, you go together. And that's at the essence and the heart of what we do at Morehouse School of Medicine. We're committed to serving the underserved, to giving people the things that they need, in the ways that they need it, at the times that they need it, because we believe in equity and we want to go further than that. We believe in justice for our communities. In 2023, no woman should die from preventable causes related to pregnancy and severe complications. This should be the most wonderful time of that person's life, not where they're planning a funeral or the families are planning a funeral. And so we love and encourage partnerships and would want to work with all of you if you're committed to the cause and you're committed to saving Black and Brown birthing people and people of color. And I want to thank you for giving me this opportunity to share the work that we're doing. Here's information on our website if you want to learn more about our center and hear more about the work that we're doing.